We have our government or Minister of Health actually hinting at sort of a segregation policy where he might create policies to exclude unvaccinated individuals from government services, from public activities, maybe going into government building, using public transit, and so on and so forth. What if you have a message right now to the government of Jamaica on the segregation between vaccinated and unvaccinated, what would that message be?
Well, first I would say the message would apply to Canada too, because the Canadian governments are looking at the same policies. This is, governments seem to be acting in lockstep on this. And I would say to the governments, please look at the science. Listen to the scientists. Please open your eyes, consult with the vaccinologists. Look at all of the experts who have an understanding of the disease. Look at those, listen to those who have information to offer, and please rethink these policies, because they are not going to have the intended intended effects. They can only have negative consequences on society, and it will further divide society. These are very dark times. This is not good.
Dr. Bernstein, can you hear me?
I sure can. Good morning.
Good morning, good morning, good morning. Thank you very much for joining us. We could not get any doctors in Jamaica to come on this live, but we got a doctor from Toronto, Ontario. Wow. So yes, that's right.
Where are all the Jamaican doctors?
Where are the? I don't know. I don't know where they are. So as I said in my email to you, most of the doctors that we've spoken with, at least I've spoken with, they are afraid. They're afraid of losing their license. They're afraid of losing their job. So they're not going to come online, come and talk to the UIC and tell the Jamaican people the truth that they need to hear about how they can properly protect themselves against this disease called COVID-19. So Dr. Bernstein, you're here to talk about the methods that you have used that resulted in your statement that you've never lost a COVID-19 patient. And before you respond to that, I'd like you to tell the Jamaican people who you are and what your qualifications or certifications are.
Sure. Well, I'm a family physician in Toronto, Canada. I graduated from the University of Toronto in 1990. I've been practicing in my own private clinic since 1992 till present. So I have a broad-based, general family practice. I see newborn cares right up to end-of-life care. So I treat, as an outpatient, all types of, acute illness, chronic illness, and provide longitudinal care, to my patients, their families, and now, seeing generations of families within my own practice. I do have a hospital affiliation, but I don't provide any more services within the hospital. I don't work in an emergency department. It is exclusively in my office setting. I also do some other work as medical advisor for a service called Metabolic Balance Canada. This is a nutrition program run in 35 countries around the world, conducted by certified coaches, and I provide support to the coaches who are conducting these plans, usually for weight management. And I've been doing that for probably about 6 or 7 years. That's a little bit about me.
Great. So now let's get back to the issue. You've never lost a COVID-19 patient. Can you tell us about that? How were you able to save so many lives?
Sure. Well, let me describe COVID within my own practice and the different waves that we've had within Canada. So Canada's gone through 3 waves. The initial wave starting last a year ago in the winter spring months I just had within my own practice, I have about 1,200 patients. So this is a, fairly standard size, family practice. And I am sort of at my limit in terms of ability to care for more patients. I had just 3 patients who were COVID positive during the first wave. And this was within one family. And we didn't know much about, COVID at the time in terms of managing them, if there were any treatments. But this family, they all recovered. They did not require treatments. They weren't hospitalized, and fortunately recovered without incident. And fortunately, most people who will generally have a mild illness, it's people who have what we say comorbidities. So increased age, obesity, hypertension. The more risk factors you have, the more likely you will have severity of disease. But the younger you are, the healthier you are. In general, it tends not to be severe. In general, there are always exceptions, but in general. So after those 3 patients recovered, I did not see any other COVID patients, or when I see, it means I did not deal in my own practice with any further COVID patients until the second wave. So I went 7 months without a single patient within my own practice as testing positive to COVID-19. When the first wave sort of was on its decline slope back in, I guess, around June, the summer months were like where it is right now in Canada. The numbers are very low, although they are starting to slowly creep up, I believe. But I didn't have any further cases until around September, when the second wave started increasing. And there weren't many, but I had no patients that had any type of severe illness at the time. They all recovered. It wasn't until November when I dealt with my sickest patient. And this was actually a colleague of mine who's a nurse whose mother was ill with COVID-19. She had, she's over 60. She had been to the emergency department twice. They sent her home without any treatments and said, go home and isolate. And during all this time, I had been looking at all the research regarding, available possible treatments, off-label treatments for COVID-19, many of which were being suppressed or censored. But I'm looking at the science. And so, in the beginning, all the discussion was regarding hydroxychloroquine, which became very political, and yet is still an effective product when used early. Then data started coming out, I'd say around April of last year. So we're talking 2020, when I heard about the first studies pertaining to the old medication Ivermectin, which is an old antiparasitic, which has been around for about 40 years. And all the data seemed to be showing that there is benefit. There were really no trials saying this, this product is a dud. Now, all of the trials were being conducted in countries, nothing in North America. We had Egypt, Bangladesh, some Kenya, Brazil, all sorts of countries, doing these clinical trials and, demonstrating benefit. These were not the large, huge randomized controlled trials that the large pharmaceutical companies do when launching new products. But it seemed that there was something to this. So I decided back in November with this sick patient, I would like to try Ivermectin, for the first time with my patient off-label. So I, followed the guidelines that had been written by the Frontline COVID-19 Critical Care Alliance, who's a group in the United States who headed by Pierre Corey and Paul Merrick and others, and who have been who created guidelines for early outpatient COVID management. And at that time, in the fall, they had introduced Ivermectin to their protocol. So I decided I'm going to give it a try on this patient, and I prescribed 2 days of therapy for her. Within 24 hours, she had dramatic improvement. Her son sent me a message saying, this is, amazing. She's already feeling significantly better after the first dose. So it was really at that point that I realized, I think, although I didn't have much clinical experience prescribing any treatments at this time, I felt this gave me enough comfort to want to use it with more patients and start treating more patients who presented with COVID-19. It never made sense to me that, here we have this condition and the standard of care is basically no care. If you get diagnosed with COVID-19, you get a PCR test, it comes back positive. You've gone to a testing center or the hospital, they do the swab, it comes back positive, and you're told, go home, go isolate, drink some fluids, wash your hands, take some Tylenol, and do nothing. And if you get worse, if you can't breathe, if your lips turn blue, you come back to the hospital. And it didn't make sense that we're not treating a disease, an infection that can be treated early. I know of no other disease state in medicine where we don't treat, where we have this, what we call a therapeutic nihilism. We just leave it. It just doesn't make sense. As a comparison, if we take a condition like diabetes, if someone is diagnosed with diabetes, if their blood glucose goes high, we have medications, we start treating. We don't say, we're going to leave this until you're in diabetic ketoacidosis, where you're so sick, you're in the hospital, your sugar is 30, and you need intravenous and insulin to stabilize you. You've lost opportunities to treat. It's the same thing with COVID-19. There are medications. They are not what I would say officially approved, meaning they don't have the on-label approval for use in COVID-19. So, what does that mean? It means the drug manufacturers that make the product haven't gone to the regulators. So that would be like in Canada, it would be Health Canada, or in the United States, it would be the FDA. The manufacturers haven't gone to the regulators to say, hey, we'd like to get a approval to use this medication to treat COVID-19. And I think the main reason that this hasn't happened is because when products have been around a long time, they are off patent, meaning they're no longer manufactured by a sole source manufacturer, where there's going to be a lot of profit in the product. If anybody can make the product and it's not very expensive, then no one is interested in going to the regulators to say, hey, let's get approval for this. So that's why we say using these so-called repurposed medications that have been around for decades, we call them off-label, meaning it doesn't say you're not allowed to use it. Physicians have been prescribing medications off-label all the time. We do this in our practices with many, many different medications that are used off-label. For example, for pain management, we use certain anticonvulsant medications off-label to help manage nerve-type pain. So we do this all the time, where physicians are quite comfortable doing that. It's all a matter of having informed consent. You have a discussion with your patient about use of a medication, and then this is what I do with my patients. I tell them that there is evidence to use these medications. There are many clinical trials that demonstrate that there's benefit. It's never a guarantee. These are the benefits. These are the potential benefits. These are the potential risks of the medication. You discuss any potential adverse reactions, and then you make a decision with that patient. So that has been my approach the whole time. And so since that time, I have treated numerous patients. It's not in the hundreds like many of the other physicians, certain physician groups in the United States and South Africa. For example, doctors Tyson and Farid, where they've treated I think thousands of patients, or Dr. Chetty in South Africa, thousands of patients. Mine would be in probably the dozens of patients. So for those patients that I have treated early, none has been hospitalized and passed away. I've not lost a single patient to COVID-19, and I'm grateful for that. And I think one of the other things that I think is really important, and it's not just the drug therapy, but it's optimizing your immune system. So I was very clear to my patients from the get-go back in March of 2020, when the pandemic took place. And I knew with my interest in nutrition that having an optimized immune system was really important to help maintain good health. I'm also part of another organization that where we have met and we discussed nutrition on a weekly basis, and we came up with guidelines for what we recommended as the proper nutrients. And that would be with vitamin D. We had suggested everyone take 2,000 units of vitamin D because we know there's been data for decades, countless papers, even outside of COVID-19, that vitamin D is so integral to the immune system that it's not just a vitamin, it's actually functions as a hormone. It has an immunomodulatory support. So we knew that vitamin D is important to help keep you out of the ICU. There have been studies since that showed if you were vitamin D deficient, your likelihood of progressing to severe disease was significantly higher. There were other nutrients that I talked about with my patients: vitamin C, zinc, selenium, magnesium, and then quercetin. So a whole bunch of nutrients. And I sent out newsletters to all of my patients by email. I have a system where I can send out mass emails, and I told my patients, this is what I recommend to help support a healthy immune system, so that if you do get sick, that hopefully it won't be as bad as if you did not have all of these nutritionals. So of all of the patients that I have treated, there's only one patient that I did treat that did require a short hospitalization. He was treated late in the disease during the inflammatory phase. And so he did require a little more than just ivermectin. He required a brief hospitalization for 3 days, did require the intravenous steroids and oxygen, and then was discharged home and recovered well. But all of the other patients that I've treated, all were treated as outpatients and did not require hospitalizations. And the other thing that I'd like to say is, if you treat your patients early, then they don't get long COVID. And that's so important, because a percentage of patients untreated will progress to long COVID. And those symptoms can persist for months and months, and there are now protocols for that to treat your long COVID patients. But you want to minimize the risk of that happening. So early treatment with multi-drug therapy, because it's not just, I just want to say that it's not just ivermectin. There are multiple agents that we use at the right time of the illness that can be utilized. It's not a single drug therapy. We have a multitude of drugs. Use the medications at the right time for the right patients, and you customize. This is the art of medicine. It's not simply, you've got this one algorithm and you must follow this. There are many protocols that can be used, and I tailor my treatment to the individual patient, and that's the art and the beauty of practicing medicine.
So, Dr. Bernstein, thank you very much for that. I have a few questions myself, but I see a question in the chat, so I'm gonna give our viewers priority over my question. So let me ask you this question from a viewer. So the question is, Doctor, how do you apply clinical benefits of using off-label or repurposed medications versus the range of COVID-19 vaccine? Is the profit, and there's a second level to that question, Is the profit motive a central factor in the propagation of certain medications in the medical world over others?
So the thing about vaccines are not a treatment, vaccines are a prevention. So we can't use, there is the hope that if you get a vaccine in every arm, then, the pandemic's over. We are finding that in other countries right now that that's not the case. And I think we'll talk about that a little bit later. From the treatment perspective, sure. I mean, you have a pharmaceutical industry that is interested in maximizing profits. So there are patented medications, and some are good. There are monoclonal antibodies that are actually effective in early treatment. So Regeneron, for example, are a set of monoclonal antibodies. I'm not sure what the cost is, but they most have to be given in a hospital setting or a clinic setting, usually by intravenous infusion. And in Canada, at least, these are therapies that are not readily available. I don't know any patients who have received any of these therapies for early treatment. There are other therapies that are used within the hospital setting. So this would be when patients are presenting late because they haven't been treated, and hospitals have been using remdesivir, which is very expensive. It's actually a repurposed but on patent, medication, and unfortunately, it really has not been shown to have any benefit. The World Health Organization in November 2020 issued a statement recommending a conditional against using remdesivir, in that there was no clinical benefit seen as far as a mortality benefit. And at best, there were some studies suggesting a slightly shorter length of hospital stay. So it's somewhat surprising that certain medications continue to be used as a priority first line, very expensive. It's $3,000 or $4,000 per patient. I'm not sure how how countries can afford to use that versus I can't imagine why wouldn't anybody want to use inexpensive repurposed medications so that you don't end up in hospital. It just doesn't make sense.
So Dr. Bernstein, I wanna show you something. I wanna show this to the Jamaican people as well. This is the COVID-19 critical care website. So this is the prevention and treatment protocol for COVID-19. Is this the protocol that you've been using for your patients?
Not so. The IMAS is the protocol for broad-based population control. I think designed more for developing countries that don't have the resources. Mm-hmm. If you look at the IMASK protocol, so one up, click on one. Yeah, IMASK. This is, and if you click on, yeah, so this is the prevention and early outpatient treatment protocol. This is the protocol that I refer to most commonly. I mean, I use medications beyond this protocol, but this one is, I say it's one of the gold standards. It has a lot of excellent information in it. You've got all of the nutritional guidance in there. Tells you your vitamin D, your zinc, your quercetin, melatonin as additional support, and you can see there are different protocols for both prevention and early outpatient treatment. So the prevention is you don't have COVID. You are looking to prevent getting COVID by taking ivermectin on a weekly basis. That's basically the dosing. They have a protocol for taking for taking ivermectin weekly, because there's data. There are clinical trials that show ivermectin on a weekly basis dramatically reduces the risk of actually contracting COVID-19. So there are patients who, perhaps if they're higher risk or they don't want the vaccine or they can't take the vaccine, using the prevention protocol is quite reasonable. The other thing, if someone is on the prevention protocol and they happen to contract COVID-19, still possible, then you would just switch to the early treatment protocol. So in the early treatment protocol, I generally use, we have a dosing range, 0.2 to 0.4 milligrams per kilogram. The guidelines have been adjusted in recent months. They've allowed for more flexible dosing to increase the amount of ivermectin for severity, to account for increased severity of disease. Because we have found that some people are harder to treat and they require higher doses and for longer treatment durations. So basically we treat, in the beginning, my first patient, the guidance was treat for 2 days. Now I treat for, I usually prescribe for 5 days, and you can actually treat for up to 10 days. But basically you can stop the ivermectin when the patient has had a clinical recovery. So excellent protocol. There's also guidance from the Association of American Physicians and Surgeons, headed by Dr. Peter McCullough. He has another excellent protocol, uses ivermectin, uses hydroxychloroquine. It's fairly similar, but it has other options in it. He has been a pioneer in early outpatient treatment. I've been on calls with him. I talk to him all the time, and a true advocate and pioneer for early COVID patient management, because the goal is reduce hospitalization and death.
So Dr. Bernstein, let me ask you a question. It's a very loaded question, by the way. From your professional experience as a medical doctor, can we use the eye mask protocol to actually stem infections, stem serious illness, stem death caused by COVID-19 and end this pandemic?
Absolutely. It's been seen in countries, regions, cities that have implemented broad-based ivermectin use, that you drop your hospitalizations within 2 weeks. So Mexico City did it. Many of the provinces or states in India, India had a very difficult spring. You saw in the news people hospitalized, dying left, right, and center. The case counts and illness went right up, but also it dropped precipitously. And ivermectin has been a very important part of the protocols within India. Uttar Pradesh being one of the states that has been very good with use of ivermectin. So yeah, if it were given to everybody, if it was broadly available and encouraged
for $1 a day, by the way, just to let you guys know the cost of $1 US a day.
It's inexpensive in India. It really depends on where you are. In Canada, it's a little more, it's different. It's a little more expensive. It's not as readily available. You can't get it in most pharmacies. We have to get it mostly from compounding pharmacies, because there are no other. There is only one official manufacturer for Canada, and that is from the original product from Merck. And it's not available. It's on back order till the end of the year at least, so you can't get it. And even so, their product is about $3 Canadian per 3 milligram tablet. So treatment with the stromectal version of ivermectin is actually quite expensive, but the compounded version of ivermectin is quite a bit, is much less expensive. But if I strongly believe that if countries were to implement broad-based ivermectin use on a population-wide scale, everybody had it in their hands ready to go. The evidence would suggest the pandemic would be significantly curtailed. I'm not sure we can say we can end it completely. I think it's fair to say we're going to have to live with this for some time as an endemic infection, and we have to learn how to live with it and manage it.
But the point is that we won't require these draconian measures of lockdowns and curfews to control a virus. So I want to show you something, Dr. Bernstein. I want to know what you think about it. Let me know if you can hear the audio, because sometimes I do have some trouble with this. Let me, okay. Can you see my screen?
Yes.
Okay.
We're looking at an orally administered, maybe 7 to 10 days, given to person who is early on in the course of their infection before you get to the cascade of events that lead to the aberrant activation inflammatory response that kills people. Because we know now from a lot of experience with the care of these individuals that if you can keep that virus from going to the upper airway, to going down into the lung and other organ systems, you can change what could be a devastating disease and make it an upper airway common cold type approach, which is really what we need to do.
Well, I agree with that.
So, one second. Let me fix my mic here. Having some issues. A second. Okay, stop the share. Okay, can you hear me?
Yes.
Okay, so the reason why I played this video is because this is the same guy and his friends that were criticizing doctors like yourself for saying what he just said. Doctors have lost their livelihoods. They've lost their licenses. They've lost friends and families. They've been kicked off of social media, Facebook, Instagram, LinkedIn, Twitter, YouTube, you name it. They've been forced underground. And I want to know what you think, how you feel about Dr. Fauci saying this right now at this time, knowing full well that you were right all along.
Well, the history books will will judge him accordingly. There have been many flip-flops over time. We have been saying all along that early treatment is critical, and those medications have always been here all along from day one. Now, I believe he is referring to a new medication that's being manufactured by Merck called molnupiravir, an antiviral, which may be the reason why Merck is not interested in the marketing of Ivermectin. In fact, they've taken an official statement, a stance that Ivermectin is ineffective, that there's no safety data on it on February 4th on their website. That is what they promoted, and that's what many organizations refer to, in that Merck states that ivermectin doesn't work for COVID-19, therefore you should not use it. But from the business interests of the company, they're looking at this expensive new product that incidentally did not work on the hospitalized patients. They found that there was no efficacy, no benefit when used in the hospital setting. And so they abandoned that part of the clinical trials since it showed no benefit. So it functions as an early antiviral. I think one of the benefits of ivermectin over molnupiravir, and I know nothing about like safety data of molnupiravir or really anything else at this point, except that it's going to be, I think, fairly expensive as an oral antiviral. But ivermectin has benefits at all phases of COVID-19. It's not just an antiviral, but has anti-inflammatory properties. So it can be used at any stage, although using it early works best. When you treat the disease early, I mean, Dr. Fauci is correct. You don't want the disease to progress to the lower airways and end up in that inflammatory phase, usually starting around day 8. Patients can get sick very quickly. Their oxygen levels drop. They can't breathe. They require oxygen, and they require much more aggressive therapy. You want to try to prevent that from happening. So that's where early treatment is important. Unfortunately, Dr. Fauci has not been a proponent of any of the other repurposed medications. There's not enough data, blah, 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 but it sounds like he's ready to endorse a new antiviral product that hasn't been used very broadly yet. Probably the clinical trials are with patients in the hundreds, whereas with all of the ivermectin trials and the hydroxychloroquine trials, there's thousands of patients in those. So to say that there isn't the data for the other medications is just completely not true. That's not following the scientific evidence. It's there. What I would say about certain medications like hydroxychloroquine is it doesn't work or it doesn't seem to work very well at all, I think, in the hospitalized setting. So it's a appropriate use for early treatment or even as a prophylaxis as well as a potential prevention.
And we've heard that this is the reason why parts of Western Africa, like Nigeria and Ghana, they're not experiencing massive outbreaks and deaths like the rest of the world, because they've been using ivermectin since the beginning of this pandemic. Right?
Really, it's not rocket science.
Yeah.
You have journalists who say, well, we don't know why these other countries are not experiencing outbreaks. Well, you look at what they're doing.
Mm-hmm.
It's
crazy. It's crazy.
It is crazy.
Yeah.
It is crazy.
Right.
It's many of the developing countries that are leading. They're far further ahead than the Western countries in terms of managing the pandemic in their own countries. It's really been quite. It's sad. It's a sad time.
So my other question for you now, and this is a contentious issue, even in Canada, as they begin to vaccinate children at the age of 12.
Yeah.
Eventually, they're going to start doing the same thing in Jamaica. What is the risk to children of COVID-19?
So the answer is very, very low. The likelihood of a child having a severe illness and dying is close to zero. It's almost zero. And usually the ones that unfortunately may pass away, from COVID-19, as few as they are, most of the time there are comorbidities, underlying health issues. But in general, children handle the virus quite well. They have, a mild cold, a sniffle, runny nose, a little bit of a fever, and that's it.
And so, and now we hear the Canadian government. Well, not the Canadian government. We hear the provinces, the provincial governments, actually saying it's time to mandate vaccines for teachers and for health professionals. So my question, so we've been hearing what's been going on in the news, and even CNN is reporting it. CNN, who's been knocking doctors on your side of the spectrum, CNN has reported it, that the Delta variant, the vaccinated and the unvaccinated have the same viral load of the Delta variant and the same ability to transmit this virus to people. So my question to you, if the vaccinated and the unvaccinated can transmit this virus to children or to their patients, what is the need to require mandatory vaccination for them?
I can't make a claim that there should be mandatory vaccination, for anyone. I think you can make an argument for mandatory vaccination if the vaccine was what we say a sterilizing vaccine, meaning it creates a true immunity. It prevents infection and prevents transmission, where you really break the cycle. And of course, if it's safe as well. But as we're seeing in other countries like Israel, the United Kingdom, and the US, it doesn't matter whether you've been vaccinated or unvaccinated. Both groups are contracting the virus and are both able to transmit the virus. So I'm not sure what vaccine mandates are going to accomplish, because a child having the vaccine, really, the concept of being able to hug, grandma doesn't make sense, because that child who's been vaccinated can still get the virus and transmit it, to granny. She can still get sick.
Yeah.
So it's concerning that we have governments that are and workplaces that are schools, institutions that are implementing these vaccine mandates.
Mhm.
And I believe it's not going to accomplish what they set out to be. It's not going to break the cycle.
And
I will, again, make the claim that vaccinated patients who contract COVID still need treatment. They still need if they want to reduce the risk of hospitalizations, because vaccinated persons in Israel and the UK are still ending up hospitalized.
Mhm.
However, what has been noticed so far is that the death rates are quite low, even with the Delta variant. People are ending up in hospital, but we're not seeing that huge onslaught of deaths. I think there still will be deaths if people are untreated. But again, if you treat patients early with multi-drug medications, inexpensive repurposed medications, whether you're vaccinated or not, you're going to reduce those risks of hospitalization and death.
And we saw a release by Pfizer recently. They're saying that the immunity from their vaccine is slowing down, is being reduced. And then they recommended that not only do you take the vaccine, but that you take an oral pill with the vaccine as well. So they're now talking about the vaccine and an oral pill. That's something that I wanted to put out there.
I don't know what that oral pill is. Do you know what it is?
No, I don't. They didn't say. They did not say at all. They just made a Twitter post and say that, oh no, or vaccines, the efficiency, the effectiveness is being reduced. We're gonna need to give you a pill with it. And then Moderna is now saying that you're gonna need a booster shot. I can't recall when they said. I think it was October, November, or something like that. They're saying that you're gonna need a booster shot for the vaccine. But let's. I want to move on from that, and I have a question for you, a specific question for you, because I need people to understand this. A lot of people are comparing the COVID-19 vaccines to the polio vaccine or the flu vaccine or any of those past traditional vaccines. So I want you to explain to the Jamaican people the difference between the mRNA, the vector adenovirus, and the traditional vaccines. And just to clarify, the Pfizer and the Moderna are mRNA, and the AstraZeneca and the Johnson & Johnson are adenovirus vaccines. So you can go ahead and answer that question.
So the mRNA vaccine, basically, they contain the genetic code for the spike protein. So it's a sequence of messenger RNA. It's encapsulated in this, what we call lipid nanoparticles, and it's injected into the deltoid muscle. And then what happens is it's taken up, the messenger RNA enters the cell cytoplasm, so within the cell wall, and there are ribosomes. These are the structures within the cells that transcribe the messenger RNA to manufacture the spike protein. The spike protein is the protein on the surface of the coronavirus. And by generating the spike protein allows an immune response by the body to produce antibodies to the spike protein. So once you have antibodies to the spike protein, that is how one is presumed to have immunity, but it's basically just to that one protein on the SARS-CoV-2 virus. With the adenovirus vector vaccines, basically it's a DNA vaccine, DNA code that is inside this adenovirus. The adenovirus is basically an inactivated cold virus. It's not able to replicate. So it just basically acts as the transport medium. So the DNA of the adenovirus enters the cell nucleus of your body cells. It produces the RNA from the DNA, and then the RNA is then transcribed into the spike protein and expressed on the cell surface and may circulate as well. So it's basically producing all the vaccines, these type of vaccines, whether it's messenger RNA or adenovirus, they are producing the spike protein in order to mount an immune response. A traditional vaccine, basically you are like a flu shot. It contains inactivated viral protein. So a portion of the virus is what is contained within the vaccine itself. And by injecting that, it will directly stimulate an immune response. So these vaccines are certainly not traditional. I think there are some traditional type.
Like the Novavax.
Well, so Novavax it's still not a traditional vaccine. It contains a fixed amount of pre-manufactured spike protein. So it does contain like spike protein itself versus a more fuller part of the virus, like I think the Chinese vaccine is a traditional protein, like traditional virus, inactivated viral, where they take the virus itself, they inactivate it, so it's not able to replicate.
Yeah.
And that's sort of my understanding, but I know much less about the other vaccines. So again, at the end of the day, the current vaccines are production of spike protein, but that in itself can be problematic in some patients because the spike protein from the virus itself is potentially pathogenic. So some of the diseases caused by COVID-19 is caused by the spike protein. So on the same token, some of the adverse events from the vaccine are presumed to be from the circulating spike protein within the body and the different tissues.
Yes. And the traditional vaccines, how would you compare them to what they have now?
Compare it in terms of what we have. This is new technology. There's never been a coronavirus type vaccine ever produced before or released on a population under emergency use or interim order authorization. So it's hard, we really have nothing to compare to. Certain vaccines are more effective than others. Flu shots, the annual flu shots have quite variable efficacy. I'd say typically in recent years, they've been deemed to be at the lower end of efficacy, perhaps 20%. Sometimes at best, they're 60 or 70% effective based on, usually they contain 3 or 4 different strains of the influenza virus based on what's been deemed to be circulating in the previous year. So that's why the flu shot is different every year, containing different strains. But but overall, the efficacy rate of the flu shots has been fairly low. But you want to, I guess some efficacy is better than none. But other vaccines like measles, mumps, rubella are quite potent. They are sterilizing. They generally produce a much stronger immune response. Or the chickenpox virus, the polio vaccine.
Yeah,
these are the sterilizing type of vaccines that do, produce a good immune response and do tend to prevent transmission, prevent disease and prevent transmission.
Yeah. So, and from a personal standpoint, and many don't understand this. Many think that people who don't want to, take vaccines are anti-vaccine, right? So I'm going to tell you personally, right here, right now, that I am going to avoid taking any of these COVID-19 vaccines, and I'm going to avoid giving any of these vaccines to my children. And that's my personal choice, right? That's my family's personal choice. But in the same breath, I brought my son to his pediatrician yesterday to get his measles shots, right? So just simply because I don't want to take a COVID-19 vaccine doesn't mean that I'm anti-vaccine. I just don't want to take that vaccine. Right. I don't want to give it to my children. Right, I'm more comfortable with the others, with the measles vaccine and so on and so forth. Right.
Yeah, so, I completely agree. I think that this is unfair labeling of individuals who have concerns about the current vaccines, it is not fair to dismiss the concerns.
Yeah.
It is not fair to dismiss the adverse event profile. These vaccines are not without risks. If you look at the VAERS database, particularly, you are going to see a lot of issues. And I have, within my own practice, I've seen many adverse events, and these events have been, significantly higher than other vaccines that have been developed. So, I agree that most people who are uncomfortable, taking the current COVID-19 vaccines, I think people would feel quite comfortable if they had comfort knowing that the vaccines were both safe, that the safety has been proven over longer term trials, and that the vaccines are effective. I don't think anyone would hesitate, taking them. But I understand the concerns that people have, and there may be potential contraindications to taking them. You may have a medical condition. You may have an allergy to polyethylene glycol that may result in an anaphylactic reaction. There are people that legitimately should not take them. You can't call them anti-vaxxer. That's just not fair. That's discriminatory. It's not right.
Yeah.
But to be concerned is not the same as to be labeled an anti-vaxxer.
Yeah. And I want to get to our final point before I let you go, because I know you're very busy. So there has been confusion out there because of how we refer to COVID-19 and how we refer to SARS-CoV-2. Most people don't understand that SARS-CoV-2 is the virus that causes the disease called COVID-19. So most people don't understand that. But something that I recently found out is that while SARS-CoV-2 is a respiratory virus, COVID-19 is actually a vascular virus. That's something that I was seeing recently. So what are the implications of this?
So, COVID-19 is a multi-systemic disease. It's not just vascular disease is part of what can go wrong in the disease called COVID-19. Mm-hmm. So certainly in the inflammatory phase of COVID-19 disease, clotting is an issue. And that's why in these protocols, we see, if you look at the hospital protocols, the Math Plus protocol, you see all the anticoagulants, the blood thinners, and also in the IMAS protocol, aspirin as a blood thinner is recommended, 325 milligrams, unless there's a specific contraindication, and that's because of the potential clotting. What happens is you can have effects on the platelets from, I think, from the spike protein, in that it can cause platelet agglutination, where you get these thrombosis or clotting, or platelet degranulation, where it's fairly rare, but basically the platelet levels will drop down to zero, and you can hemorrhage, you can bleed to death. Yeah, with catastrophic strokes. So that is the clotting component. But there are many facets. You've got the neurologic, you've got cardiac. It really affects all of the systems potentially. Again, the importance of treating early to prevent or reduce the risk of these complications.
Yeah. So before I let you go, Dr. Bernstein, do you have any last words? So just to give you a heads up about what's going on in Jamaica right now. We have our government, or Minister of Health, actually hinting at sort of a segregation policy where he might create policies to exclude unvaccinated individuals from government services, from public activities, maybe going into government building, using public transit, and so on and so forth. If you have a message right now to the government of Jamaica on the segregation between vaccinated and unvaccinated, what would that message be?
Well, first I would say the message would apply to Canada too, because the Canadian governments are looking at the same policies. This is, governments seem to be acting in lockstep on this. And I would say to the governments, please look at the science. Listen to the scientists. Please open your eyes, consult with the vaccinologists. Look at all all of the experts who have an understanding of the disease. Look at those, listen to those who have information to offer, and please rethink these policies, because they are not going to have the intended intended effects. They can only have negative consequences on society, and it will further divide society. These are very dark times. This is not good. These type of you only have to look back into the 1930s, 1940s, when these sorts of segregation policies took place with devastating effects. It didn't work out well, and I can't see that doing something like this will work out well and benefit society as a whole. I think we have to work together to end this pandemic. Keep working on vaccines, finding safer and more effective vaccines, and encourage the early treatment so that we don't have to do these draconian policies, and we can end this pandemic. I want to remain hopeful with Jamaica and with Canada that this is something that we can manage and should manage and end this pandemic and learn to live with this virus successfully and mitigate the harm.
Wow. Thank you very much, Dr. Bernstein. It was really great having you on today, and I'm hoping that we can get you back to actually talk more details about this. And actually, we might be inviting some Jamaican doctors to possibly come on our show after they see your video. They might be influenced to come on the show, and then we can actually create a little conference, and we can actually discuss this issue publicly, and then we can see what we can do further from that. We can see if the government would actually listen to what the experts are actually saying. Thank you, Dr. Bernstein. Have a good day.
Thank you very much, and I've enjoyed our discussion, and be happy to join a panel and have that dialogue.
Yes, great.
Okay.
Bye.
Bye now.
So there you have it. That was Dr. Ira Bernstein, a doctor from Toronto, Ontario. He has never lost COVID-19 patient. He has been treating patients using a process called early outpatient treatment. So I hope you heard what he said. He's saying he told the Jamaican government, he told the Canadian government, listen to the experts. But I want you to ask this question. If the government is not listening to experts right now, who are they listening to?